Professor at the Department of Ophthalmology at the National University of Singapore and Professor of the SingHealth Duke and US Ophthalmology and Visual Science Academy clinical program. Among different international posts, Professor Mehta is a member of the board of directors of our Corneal Society. Professor Mehta is not only a great surgeon and a great clinician, he's really a very good researcher, and I think it's great to have him today speaking about SMILE and bringing some of the information he's been gathering for the last 10 years. So without further ado, it's a really pleasure to have you, Jod, and thank you for accepting and being here so late in Singapore. So thank you very much, and I will stop sharing my screen and you can start sharing yours.
Great, thank you, Arturo. Great. So thank you for the kind invitation, and thanks for coming in so early in the morning, everyone. So okay, okay. Write this down. Okay, so you can see the screen, yeah? Okay. Yep.
Yes.
Yep. Okay, great. So Arturo wanted to give you a talk on SMILE. So the title we stuck with was everything that you need to know about SMILE, but I had to put a little caveat to that and put almost everything that you need to know, because I can't tell you everything in 25 minutes. Basically, that's probably, you'll see work that we've done and other people have done over the last sort of 9 years. So I think it's good to get a bit of an introduction to understand basic concepts and how this procedure works. And I mean, a lot of these topics individually, I can talk for almost an hour on them, or yeah, specifically itself, but it will give it a good overview. So I'm a consultant for some of the companies that do SMILE lenticular technologies, particularly Carl Zeiss and also Zima as well. So let's just start with LASIK. LASIK is a very common refractive procedure, and we have to bear in mind it's probably the most successful procedure performed on the human body. And several studies have shown how successful this procedure is, and no surgical procedure has undergone as much intensive examination as LASIK. And generally, most people are happy. We have to be honest about this. 95.4% of people from the PROUD study were actually very happy with their outcome. But if you look at the total number of people that had the procedure, there still leaves a significant number of people that are unhappy about the procedure. And you do see things like this on the internet. I remember going to ASCRS one year where there were people actually picketing outside the conference center because they were unhappy about basically the LASIK as well. And LASIK success, you have to bear in mind, is built on the fast rehabilitation with the vision. It's a painless procedure. It is relatively simple, and technology has helped us huge amounts with this and about improving outcomes over the last 20 years. If you look at reasons why people are unhappy, however, with their LASIK, it's either related to flap-related complications, and I agree with most people that I think that obviously using a femtosecond laser to create your flap, the risks are basically less. Residual refractive errors, worsening of the ocular surface disease, visual symptoms which are less with better excimer programs now that we have, biomechanical weaknesses, which is obviously something that worries us all about inducing ataxia, and of course regression. So if we wanted to basically improve on this, just hypothetically, we'd want a procedure that has no flap, that has a better corneal innervation to help with the ocular surface, and has improved biomechanics, okay? So we can try to improve the biomechanics, and ideally would induce less energy so that we'd get basically less regression. Okay, so let's look at these first 3 points in red over here. So we started doing SMILE back in 2011, and the laser we were using back at this time is the VisuMax laser, and we have two VisuMax lasers. They're identical. One is in the clinical facility is on the left-hand side, and one is in our animal facility on the right-hand side. And left, you'll see a patient undergoing SMILE. On the right-hand side, you'll see a monkey undergoing some investigation where we're checking the IOP, so it could be some IOP measurement itself. But the lasers are exactly the same. And in fact, the animal laser has a complete, full optimized protocol, so we can do stuff and software and things that we can mess around with this machine that you cannot do on a standard clinical machine, because there's no restriction for what we can do. So this allowed us to do a lot of studies on animals when we got this laser back in 2011. Now, the first thing to understand is that how do femtosecond lasers work? So they work on a principle of what we call photo disruption. So basically you fire a laser pulse and what happens is you get a cavitation bubble formed around the pulse itself. And the second pulse you fire next to it, you get another cavitation bubble. So I tell the residents, it's like thinking about a YAG laser, except it's very, very fast. It's 10 to the minus 15 seconds. The cavitation bubbles themselves, as they basically coalesce, you get a resection plane, like you can see in this histology picture on this side, and this what allows you to create patterns and shapes inside the eye. Now, the issue is this is very simple when you're talking about a two-dimensional object, but when you look at a lenticle, of course, this is three-dimensional. So what you need to be able to do is not only be able to cut an X and Y axis, but also X, Y, and Z axis as well. And it's the Z axis focus that distinguishes all the lasers that can do SMILE compared to those lasers that can't do SMILE. In this study over here, we were basically comparing the Intralase to the VisuMax. The VisuMax was the prototype laser to do a lenticle extraction. Intralase, we know we can't do lenticle extraction. We use a very interesting technique called helium-ion microscopy, which normally they use basically for engineering. What you can see is really showing two things over here. So if you measure these pore sizes and distances, you will see the Intralase, the spacing is about 9.2 microns, or with the VisuMax is basically about 4 microns. So you get much tighter spacing with the VisuMax laser compared to the Intralase. And the reason why that works, the reason why that is that the Intralase is a much higher energy laser. So it's working in the microjoule regions itself. So it's using the photocavitation to drive the whole process of creating a resection plane. The VisuMax, however, because the spacing is basically smaller and the energy level is in the nanojoules, so about 135 to 110 to about 145 nanojoule range itself, the spot spacing has to basically be closer together when it basically, in order to create the refraction plane. But the key thing about this picture is the bottom ones over here, J and K. And what you'll see is how tight the Z-axis focus is. On the Intralase over here, it's a 4 micron depth into tissue, while with the VisuMax, it's only 2 microns. So if you want to get a lenticle in 3 dimension, you've got to have a very tight Z-axis focus. Otherwise, every time you fire a laser pulse, it's going to basically not go into the same depth of the original pulse that's fired into later. It doesn't matter when you're creating a laser flap for LASIK, but it does matter if you're creating a 3-dimensional shape with a lenticle. And what you'll find is that all the lasers that can create lenticles, and we'll talk about some of the other ones later on, have all a high numerical aperture to allow them to basically have this tight Z-axis focus. Now, the first study that really came out, I saw this at a private meeting in Barcelona in 2009, 2010. And what you can see, this is a study from Rupal Shah in India, where they did 329 eyes of 173 patients. And what you can see is at 1 week post-op, the visual acuity results at 2020 at 1 week were only 33%. This is a pattern in red line over here. But you can see that there was a sudden increase of 66% when the scanning pattern basically changed. And what we called this paper was scanning pattern A and basically scanning pattern B. So the scanning pattern in which the lenticle is actually created have a direct effect on visual acuity. This is basically just a summary of the different types of scanning patterns. So if you think about the lenticle creation now, there's 2 ways of creating a lenticle. You cut the posterior side first, and this can be basically what we call from outside in, or basically what we call centripetal cutting, or it can be basically from inside out, or what we call basically centrifugal cutting. And with that, you can do a combination on the anterior cut, again from inside out, so centrifugal, or from outside in, so basically what we call centripetal. And these are the 4 patterns that possibly you can cut with a lenticle. So what we wanted to do was to see whether we could understand why was there a significant difference in the visual acuity when you change the pattern from basically from pattern A to basically pattern B. Okay, and this is the pattern that was put into paper as pattern A, and this is the one in red. Sorry, the one in red over here was the one. That one was pattern A, and the one in blue over here was basically pattern B. So what we did is that we did a whole series of rabbits, and we changed the firing sequence of the laser. And like I told you, the laser that we have in the animal facility, I can change firing sequence, we can change the pattern, we can even change the way the laser basically fires. And what we found is that if you look at the 2 patterns, so pattern A and pattern basically D over here that you can see, and you look at the anterior border, the part that's going to basically be on the visual axis, what you can see is that when you compare the different patterns, pattern A over here give you a much smoother anterior border with respect to the collagen fibers, while pattern D over here, you can see a disruption in the collagen fibrillar arrangement. And it is this disruption of the collagen fibers that basically affect the visual acuity. So firing pattern A, where you basically fire from the posterior side on outside in, so centripetal, and basically from the anterior cut, so centrifugal and inside out, gives you the least disruption of the collagen lamella in the visual axis. And that's why there was an improvement in the visual acuity. To understand this with respect to cavitation bubbles, you can see it in this schematic on the top over here. So on the left-hand side, what you're seeing is a schematic to explain what is going on with basically pattern A. So when you fire the laser from outside in, when it switches to the front over here, there is not enough time for the cavitation bubbles to basically disrupt the overlying collagen when you're creating the anterior border of the lenticle on the anterior surface. But when you basically do it the other way, when you fire from outside in and then outside in again, you can see over here, there's a disruption of the collagen fibrillar network. So when you're firing the laser, it is not going into the same plane as a previous basically femtosecond laser shot. So what is happening is you're getting a disruption of the collagen fibrillar arrangement, and that's what was leading to a poor visual acuity. And that is why when you load up your laser now and you do SMILE, this is the pattern that you'll basically do because it causes the least disruption into the collagen lamellae. And we published this back in 2012. Okay, so that sort of started the whole sort of real XI. So now you know how to create a lenticle optimally. And initially there were 3 procedures. Of course, the only machine that was able to do this was the VisuMax. The 3 distinct procedures were what we call flex, which is the procedure over here on the left-hand side, where essentially what you did was you created a lenticle and it made a flap all the way around, which is similar to a LASIK kind of flap. Okay, and then what you did was you lifted the flap up and you simply peeled the lenticle off the bed. We started with that procedure back in 2010, 2011, and then we soon switched to a procedure that we call pseudo SMILE. So basically, essentially what happened is that you cut a flap all the way around, but we didn't open up the whole flap. We moved the hinge to one side and we just opened up the superior area. So there was no flap lift. And this incision was about 5 to 6 millimeters at the top. And then of course, back in 2012, when we got the SMILE software, we soon switched to basically doing SMILE, where there's of course no flap across the top area, and your incision size is typically between 2 and 3 millimeters. So there are some distinct differences between SMILE, as you can see on the right-hand side, and LASIK on the left-hand side. So of course, SMILE is an all femtosecond laser procedure. Femtosecond laser work in the infrared zone. Okay, so it's a completely different energy setting when you compare it to LASIK, which is using an excimer and a femtosecond laser. There's a different learning curve. It's a different procedure. It's a small incision procedure where you have to basically extract the lenticle. Or with LASIK, obviously, once you lift up the flap, the excimer laser effectively is doing all the work with respect to centration and putting down your basically ablation. Centration is key in LASIK, and of course, it's controlled by the laser. We have all the machines now have very good trackers on them. They control your movement. With SMILE, and we'll talk about this later on, the centration is done by the surgeon. When you look at the effect of the hydration, it's very different. While with LASIK on the left-hand side, the stroma, the flap is basically lifted up, so that you do have an effect of stromal dehydration and flap shrinkage, especially if you're doing basically moderate to high degrees of myopia. But with SMILE, because it's all encompassed within the stroma when you find the laser, there's less effect on basically stromal hydration. When you look at the energies of the laser, of course, the femtosecond laser is much more stable, so less risk of environmental change compared to the excimer laser, which you have to keep on doing fluence testing to make sure the energy is fixed. And likewise, SMILE is less sensitive to eye movements. That's why you need the tracker with the LASIK to follow the eye movements. But with SMILE, when the lenticle is being created, of course, the laser is actually fixing the eye into position. And this is important, especially when you're doing moderate to high degrees of myopia, to reduce the risk of basically getting patient fixation fatigue. So how do you perform the procedure, or how do I perform the procedure? So the first thing is basically fixation, and we'll talk about this in a little bit more detail. Initially, the patient is going to fixate on the green light, and we can talk about different areas to fixate, whether you use the corneal vertex or you basically do on the center of the pupil axis, or you use angle kappa, and I'll explain to you which one we basically do that. Once the patient's undergoing fixation, we use the infrared beam to see how good the fixation is. You can see the infrared light there, so show me where the fixation is itself. Then the lenticle is being created, and like I said, the posterior part of the lenticle is created first, and then the outer part is initially cut in a centripetal basically manner. You can see the centripetal cutting occurring from outside in, and then basically centrifugal from inside out across the surface, and that is the optimal pattern to create your lenticle. Once it's created, it's important to delineate on the right-hand side the anterior and the posterior borders of the lenticle. So you'll see that once you basically open up the incision, there's a release of gas, so you can see the cornea changing color from white to basically clear. The patient can fixate on the light. So here again, you see the gas basically released. I will then delineate a little bit on the posterior side. So I'll open a delineation basically plane. This is using a dissector that's developed for me by ASICO. And once you basically open up the planes, you simply use the dissector to basically remove the lenticle. So we typically dissect the anterior surface first, and then we'll basically do the posterior surface. When you're using the dissector, it's important to go beyond the area of the optical zone of the lenticle. If you do that, you won't get any issues with the stickiness of the lenticle itself. And then you simply use a pair of forceps to pull out the lenticle from the eye. The last bit is very important, because what happens is that once you remove the lenticle, you're going to get a collapse of the collagen. And if you don't massage and wash the interface, then you cannot use so much water that you do when you use or fluid when you're doing a LASIK, because the fluid will get trapped in the interface itself. But I do wash the interface, and then I gently massage the surface. And what you're doing with the massaging the surface is you're moving any wrinkles away from Bowman's membrane, away from the visual axis. And if you don't do that, there'll definitely be a degradation of visual quality that you will see at day one post-op. Okay, so initially, obviously, I'm just going to concentrate on studies that are comparing SMILE and LASIK, because I think these are important, because most people are quite happy with understanding LASIK as well. So back in 2011, we published this paper, and what we did was we looked at 3 different diopters of treatment. On the left-hand side, you see LASIK going from basically from -3 up to -9. On the right-hand side, this was done in rabbits. You see basically RELEX going from basically -3 up to -9. This is basically flexed at this time. And what you'll see is on the in vivo confocal microscopy is that as you increase the dioptric power of treatment, you get an increased tissue reaction in the interface. And that's basically to be expected when you're looking at -3 treatment compared to a -9 treatment with LASIK. But interestingly, with RELEX or with lenticle extraction, when you increase from -3 to -9, there's actually no difference basically in the interface. The lenticle, of course, is thicker, but the interface reaction is exactly the same. And you see that on in vivo confocal microscopy. And likewise, when you look at the inflammatory response, you see the same thing. When you go from -3 up to -9 with LASIK, as you're putting down more excimer laser ablation, you get an increase in inflammation. While at RELEX, there's hardly any change when you go from -3 up to -9. And when you quantify this on the bar charts over here, you'll see the significant difference with respect to the interface opacity. Interface change occurs at about -6 diopters. And of course, it's highly significant at -6, and it's significant at basically at -9, not very significant basically between at -3 diopter treatment. And this is the reason why. It's got to do with the amount of energy that's laid down in the treatment. When you look at any excimer ablation, as you go basically from -3 to -9, you're tripling the amount of energy that's being basically laid down. But with RELEX, the amount of energy is almost the same. And that's because the energy to create the anterior and the posterior surface is exactly the same. The difference is the thickness of the stromal tissue or the lenticle that you're basically creating to cause the removal. And that's why you have less risk of having issues with higher energy compared to basically lower energy treatments. Now, if we look at the visual acuity results in the literature, this is a meta-analysis of 27 studies published in the literature comparing SMILE to basically LASIK. And you can see the majority of them are basically from China. Obviously, SMILE was originally approved in Europe and then basically in China, and only recently got FDA approval. What you'll see is that out of the 27 studies on 4,000 eyes comparing basically SMILEs and LASIKs, most of the studies show there's no significant difference between SMILE and femtosecond LASIK with respect to safety, efficacy, final square equivalent, vertical, horizontal coma as well. And most of the studies which looked at aberration will show you that there's less aberration in SMILE there can be compared to basically LASIK. Now you'll see the study design, most of them are clinical trials. A lot of them are prospective, some of them are retrospective. Most of them are case series where they're comparing a historical cohort of SMILE basically versus LASIK. There are 2 down the bottom over here where they're randomized control trials. But again, the randomized control trial was not done on the individual patient. It was done on different patients coming to the clinic. So more recently, you'll see in this year in ophthalmology, in this year in ophthalmology, there are 2 papers. One was the FDA approval study that was published by John Dischler in January 2020. And what you'll see is out of 357 eyes, 95.3 of them were 0.5 diopter of hemotropia, 89% were basically 20/20, which is a pretty good result for the first time they're basically using the laser. A pretty minimal complication rate, only 3 intraoperative adverse events. Our paper is a randomized controlled trial. It's a paired eye study, and we started this back in 2013, 2014, so it took about 3 years to get the right patients, because their patients are absolutely matched for the refractive error, and that's why it took a long time. Now, the interesting thing about the study is that we looked at outcomes at 3 months and also basically at 12 months. And what you can see is with respect to visual acuity results, safety and efficacy, they're exactly the same between LASIK and SMILE. But the thing that we showed is that at 1 year post-op, now bearing in mind, obviously in Singapore, we do slightly more higher power treatments with respect to myopia, because our mean myopia in Singapore is about -6. There was a 6% change in refractive spheric equivalent over 12 months in our SMILE group, and 12% change in our LASIK group. Okay, and that shows you the change in progression of myopia and the stability of myopia in that moderate to higher degree group, which is the most common treatment group that we basically do over here. Now, this is not significantly different because of the sample size number, but it shows you the difference with respect to stability of the SMILE basically over LASIK. Now, there's certain things that I think you have to take in consideration or understand the differences between the procedure. If you look at this immunohistochemistry procedure, this picture at the top, what you'll see is that this is from our paper in 2011. If you look at the amount of inflammation caused by the lenticle creation, so that's the top bigger line over here, what you'll see is there's actually no inflammation, okay? However, once you remove the lenticle from the eye, then you'll see the inflammatory dots, which is these green dots over here. So what that shows you is that you've got to have a good dissector when you're taking out the lenticle. If you have a rough dissector that's not smooth, you're gonna basically induce more inflammation. So the inflammation comes from the surgical manipulation from the surgeon, okay, which is obviously different to basically LASIK, not the femtosecond laser, okay. Other studies have basically shown this is a study from Sri Ganesh, which shows you the effect of different dissectors on the interface, and you'll see the rougher interface down over here in E will give you slightly delayed postoperative visual acuity. Likewise, we were able to show over here in this study, this was done in rabbit eyes, when we looked at 3 different dioptric powers, so 2 diopters, 4 diopters, and 8 diopters, when it was an experienced surgeon, so it was myself versus basically one of my fellows. What we were able to show was that the experienced surgeon induced less inflammation in the lower diopter group compared to the novice basically surgeon. And you were able to see the differences at 1 day. And these all basically settled down when the rabbits were on steroids basically for 1 week itself. So what I tell people is that if you're doing a low diopter treatment and it's an inexperienced surgeon, I ramp up the steroids for that person if they have more manipulation of the tissue, because you can guarantee you're going to get more inflammation in the interface itself. So we give them slightly higher dose steroids compared to those with a moderate to higher degree. So when you're starting off doing SMILE, you're better off starting with a -4, -5, -6 diopter, or obviously above that, rather than starting off with a -2, -1, or maybe -3 diopter, because sometimes you're going to increase the amount of manipulation to get the lenticle from outside the eye as well. This is the dissector I use. I don't have any financial interest in this device itself. This is the one I used to use on the right-hand side, and you see big differences in the dissectors itself. This dissector is much more curved at the tip over here. This one is a bit more pointy, and you'll see this one is much thicker than this one over here on the left-hand side. The reason why I switched was this dissector was then made afterwards. It follows the corneal curvature much more naturally, and I prefer to do much more incision. So I do most of my SMILE through a 2mm incision. And if you use a thick dissector like this, when you're doing the manipulation, you can get stresses at the edge of the incision. Now, it's not going to affect the visual acuity, but it just doesn't look nice at the edge of the incision over here. But when you use a thin dissector, you'll see some other videos later on, you'll basically avoid this issue over here when you're doing the dissection, because you can pivot around the interface. Okay. So some of the other issues that are important to bear in mind that have come into light with respect to SMILE is energy. And what we know is that lower energy gives you faster visual recovery. This study that came out of Taiwan, which is quite an interesting study, which is a prospective randomized controlled trial looking at 2 different energy levels. And what they showed was that the uncorrected visual acuity was better in those that had lower energy at day 1 and basically at 1 week. Okay, so they had less aberrations at 1 week, 1 month, and there's no difference at 3 months, however. So what you're doing is you're trying to get an earlier visual recovery in your patients by dropping the energy down into that you're basically applying into the stroma. And of course, this is important because lenticle creation is all related to the amount of energy that's basically applied in that interface. And you don't want to have it too low down, because of course you're going to get dark spots where the laser is not basically cut. So the energy does have to be optimized in different settings, temperature in the different rooms. So I work in Singapore, it's much more humid here, and there's certain places around the world, and obviously with different altitudes as well, you do need to optimize the energy. And you can tell the optimization of the energy by looking at the cavitation bubble formation on the lenticle itself as well. So let's talk about fixation, because I think this is a key and very important point. On the left-hand side, of course, you'll see a LASIK, typical LASIK case, where the patient is picking up the eye tracker. This is from an EX500, and is using the eye tracker to help with the fixation. On the right-hand side, there's basically, once you dock the laser, there's no movement because the eye is basically held in position. So the laser has to track the eye movement because the eye is basically moving with excimer-based treatments. While with femto-based treatments, the fixation is done by the surgeon when you put you put the suction on with the laser itself. Hence, that's why you do need to have a cooperative patient if you're using this femtosecond laser for your LASIK creation, for your lenticle creation. So how good is your basically centration itself? So we looked at this in a study a few years back with Cynthia Roberts in Ohio State. And there are a few concepts that you need to basically just understand before I'll show you some of the results from there itself. So treated area is a combination of your transition zone, so your blended zone, and your optical zone. Okay, so the optical zone is what you program into the laser. You have a transition of about 0.1 millimeters around the edge, and that's basically your treated area. Your functional zone is basically your post-operative outcome of what you basically get. So it's the size of the optical zone after you've basically done the treatment. And this is related to the biomechanics of the cornea. And again, but it's the actual refractive area achieved of the intended power in the patient. The way you can basically measure this is basically using this, this software. And what the software will do is if you look at the original map, basically after the surgery, it will basically pick up the point of the thinnest point of the cornea, and then basically the algorithm will basically grow out all the way up. This is done on an axial map, and then it will measure this basically optical zone and give you a data in X and basically Y axis. And we sent all the scans to Ohio State, and these were basically assessed by someone there who was masked to whether the patients underwent SMILE or underwent LASIK. So what do we basically see? What we found was that even though for LASIK, okay, we programmed the larger optical zone, the functional zone that basically the patients had was actually larger in SMILE than it basically was in LASIK. Okay, so what that means is that you get a much larger optical zone in a SMILE case than with a LASIK, because of course with LASIK you've got a flap around the edge over that thing which will shrink your peripheral optical zone, but with SMILE you don't basically have the same kind of effect. Okay, and if you look at the difference over here, the smaller the zone size basically was significantly different between SMILE and basically with LASIK, and the values over here are the ones in orange. So here you can see the measured functional zone was 30.25 in the SMILE eyes, and it was 29.21 in the LASIK eyes. And this is important because this was part of the patients who underwent the randomized controlled trial. So we controlled internally for the biomechanics because it's the left and the right eye, or the right and the left eye of the same patient. Okay, and you still achieved a larger optical zone, and the refraction that was programmed in the laser was exactly the same. So we control for biomechanics and we control for basically for refractive error. Okay, now since the last basically 2 years, there have been some cases that patients in the literature where they've compared SMILE basically to wavefront guided LASIK. So most of the studies were compared to wavefront optimized. So what about wavefront guided studies? So these are 3 studies I'm basically picking out, which were all published basically in 2017. And what you'll see is that from the studies, if you look at them in detail and you look at the outcomes, if you look at the SMILE eyes, they all had induction of basically coma. And typically this is basically vertical coma. And this was induced in all these papers. Okay, when you look at the data. So of course, we published a paper back in 2014. And I thought, this is very strange. Do we not have vertical coma in our data? So I went back to have a look at the data. And in fact, what I found is that we did have vertical coma in the data itself, but there was no significant difference between the flex eyes and the SMILE eyes. So here, back in 2012, we were doing flex and we were switching over to basically SMILE. So we compared the outcomes to show basically SMILE without a flap was superior than basically compared to LASIK, compared to flex treatment. And when you look at the percentage of people that got 20/20 vision in what we call a non-optimized situation, in our study from that paper, it was about 72%. And the ones in the literature was about 78%. The Chinese study was 90%. And John Cowanopoulos' study was about 68.2% itself. Okay. And this was because we hadn't optimized the centration. And that's why we were basically inducing vertical coma. So with an optimized centration, which I'm going to explain to you how we basically do that now, you can increase the percentage of patients getting 20/20 vision. And these are the kind of results that you're attainable with an optimized system itself. And this is why centration is really, really important to basically a SMILE procedure. Okay, so optimization of fixation is really important for SMILE. And remember, your optimization of fixation with LASIK is done, of course, by your excimer laser. How do we basically do this? So what we did is that we thought that the centration, initially we were told by Zeiss to center on the middle of the pupil. And then what we started doing was we started looking at the effect of angle kappa. And what we basically found is that if you deviate or decenter your ablation from angle kappa by about 4 or 0.5 or millimeters, so about 500 microns, you had an improvement in the number of patients with visual acuity of 20/20. You can see that result basically over here. How can you predict the patients in which you have to do the greatest deviation? Well, interestingly, they were the ones with the largest degree of angle kappa. Now, angle kappa, of course, is larger in hyperopes compared to myopes, but there is a significant number of myopes that have large angle kappa. And it's those patients that have larger areas of angle kappa in which you have to decenter the laser towards the corneal vertex or towards the angle kappa to improve your visual acuity outcomes. This study is from Dan Reinstein in collaboration with a group in Korea. And what Dan did was basically they looked at all the effects of decentration with respect to higher order aberrations. And what they showed is that if your decentration was 0.335 millimeters or 335 microns away from the corneal vertex, you had a higher risk of basically inducing spherical aberrations. And vertical coma is the key thing that you're going to basically induce if your decentration is off. Now, one of the ways you can get around this is, of course, you can increase your optical zone, okay? Because if you increase your optical zone, your tolerance to decentration becomes much less. So if you do a smaller optical zone, you've got to bear in mind, of course, you've got to be much more clear with your decentration. If you do a larger optical zone, the downside, you're going to eat basically more tissue, I mean, following Mulleren's formula, but your sensitivity to decentration becomes basically a lot less. If you look at the outcomes of these two groups, the less than 335 deviation versus greater than 335 deviation, interestingly, there wasn't a huge difference in their visual acuity, but the difference is in the aberrations. Okay, and when you compare amongst all the different aberrations, where you're looking at higher order aberrations, changes in coma, changes in spherical aberration, changes in vertical coma, or changes in horizontal coma, you'll see that vertical coma is significantly different with basically both groups. When you're doing SMILE, if you want to see your centration is good, what you do is send the patient for a scan, look at your vertical coma. If you've induced vertical coma during your treatment, you know your centration wasn't as good as you thought it was going to be itself. How do we basically do the centration? So this is typically what we will do with the VisuMax system. Now, this may be different with some of the other lasers that we'll be hearing about. So you normally mark the center of the corneal light reflex. You put 3 spots on the cornea. So there's a triangulation basically point. And this is basically where the patient is fixating. And what we try to do is we try to center the laser, or the creation of the lenticle, on the point of basically where the dot is, where the basically corneal vertex is. And that's where you need that subjective component to help you with the fixation. And as I said, you can basically know that you get less vertical coma. Typically, using the angle kappa method, which is what I showed you that we basically published in the past, what I will do is I'll look at the preoperative angle kappa. If the patient has a large preoperative angle kappa, I will deviate the laser or the lenticle creation towards the angle kappa, so it's closer to within 500 microns of where that angle kappa deviation is itself, to improve my centration. But typically what you're trying to aim for is on the corneal vertex in most cases. But if the angle kappa is small, of course you will know that corneal vertex is going to be very, very close to the visual axis anyway itself. But if the angle kappa is large, I deviate slightly more towards basically the angle kappa. What about astigmatic control? Well, if you mark the cornea, of course, basically with the VisuMax, you cannot rotate the software once you've basically done the docking. You have to actually rotate the cone. But if you look at a comparison between the theoretical impact of a purely cyclotorted ablation versus a decentered ablation, it's important you get the centered ablation in first before you basically look at cyclotorsion effect. If your ablation is decentered, you're going to basically induce the coma and spherical aberrations. Typically, what you'll find is for low dioptric SIL treatments, I find it actually is very predictable. For high dioptric SIL treatments, or anything above 1.5 diopters, there is a slight adjustment I do if I'm doing with the rule of astigmatism versus basically against the rule of astigmatism, because there will be an effect with how efficacious the laser is itself. Okay. So what are the other advantages of basically SMILE? Well, of course, with SMILE, as you can see on the top over here, there's no incision compared to basically a femtosecond laser flap on this side. So of course, people who are doing sports or risk of basically injuries to their eye, there's no risk of having any flap related complications, because basically, of course, there's no flap. But one of the other key benefits, I think, to basically SMILE is the ocular surface. And you can see over here, this is one of my patients 1 month post-op from our trial. On the right-hand side, they had a LASIK flap. On this side over here, on the left-hand side, you can see basically they had a SMILE. And typically, basically what you see is that 1 month post-op, you see this inferior punctate epitheliopathy in your LASIK eyes, but SMILE eyes, you have a much better quality tear film. And of course, this is better because, of course, you've got better preservation of your nerves on the surface of the cornea. Okay, so how do we basically know this? So a few years back when Kareem, he's on the video panel today, he did this study when he was with us where we took these lenticles out from the eye and we studied basically the nerves inside the lenticles themselves. And what you're able to see is that when you study the nerve regeneration, so this is LASIK on the top and basically SMILE at the bottom, where you compare 2 weeks over here compared to 8 weeks on this side over here, what you'll notice is that with the SMILE eyes, you get much faster nerve recovery. At 1 week, you have a reduction in subbasal nerve plexus in basically both groups, but basically by 8 weeks, you have much faster nerve recovery in the SMILE group compared to what we saw basically in the LASIK group. Now, the other thing that we basically noted was it wasn't just the recovery, it's the quality of the nerves, okay? With LASIK, you get much more sprouting nerves, so this is an indication of nerve regeneration, while with the SMILE group, you have a much greater number of these long, basically basal nerves. So the morphology is much more normal in the SMILE group compared to the LASIK group. And subsequently, so from our paper back in 2013, 2014, all these publications basically came out afterwards on clinical studies supporting exactly basically what we saw in the rabbits, whether you're looking at Contribone, OSDI, confocal, or basically Schirmer's, all when they're comparing SMILE to basically LASIK, they were all basically showing favorable outcomes in SMILE compared to what was basically achievable with LASIK. If you look at the recovery typically in a LASIK patient following refractive surgery, and you can divide this up into symptoms, which are basically in blue, corneal sensitivity, which is basically in red, the corneal nerve density, which really doesn't recover even by 50% basically by 1 year. And you can compare this in this systematic review, comparing SMILE to LASIK, just looking at ocular surface outcomes. What you'll see is that when you compare amongst the two groups, when you're looking at OSDI values and basically Schirmer's, they're much more in favor of SMILE compared to basically LASIK. And this is exactly true when you compare 6 months to basically baseline, but likewise when you also compare 1 month, 3 months, and also at 6 months. So all the clinical studies are showing you get better secondary measures of innovation in the SMILE group compared to what you see with the LASIK group. So it would be remiss of me if we not talk about complications. So complications related to SMILE can be related to incomplete lenticle creation or basically complete lenticle creation. So often these are related to basically, these are perioperative complications, so technical issues related to laser or suction loss, which is the most common when you don't create the lenticle properly, or it can be related to the lenticles basically being created, but there can be issues with the incisions, epithelial defects, or basically you're unable to basically get the lenticle out. And then it can be post-operative complications, which are typically rare. So maybe central abrasion, a bit of regression, and maybe DLK as well. So we'll just talk a little bit about these little points as well. So the two most common things you'll see are actually epithelial defects around your incision, depending on your incision size. Normally I tell people when they're starting off maybe to do a 4mm incision or 3mm. When they get more experience, they can reduce the size of the incision down itself, okay? So this is about the only video I have out of like the last 9 years or where a lenticle has been left. And this is one of my patients who had a 1.5 diopter treatment. And you can see just the edge over here. So this guy is 6'6", but I could see the edge of the lenticle over here when I did this surgery, and I thought, okay, I'll go back and took it out. So I took it out basically a week later. And you can see after demarcating the edge of the lenticle, you can simply open up the same pocket and go in and simply basically remove the lenticle. So you just gently peel this and basically take this out for him. And I think it's best to basically remove if I have any lenticle fragments, but I mean, this was well away from his visual axis, didn't affect his vision. I just wanted to basically remove it from him as well. Epithelial related complications, you can see on the left-hand side, they can occur slightly more in older people. It can also occur, of course, you get excessive manipulation in the incision itself. And the best thing to do is identify the loose epithelium, like you can see in the video. So push the loose epithelium away. And it's best to basically remove that loose epithelium, because what you don't want to do is implant it into the pocket itself. It's not like LASIK where you can simply wash it away. If it gets implanted into the pocket, it can be a little bit more difficult to basically take it out. So recess the loose epithelium around the edge and consider using a bandage contact lens basically over the area just for a day to allow the epithelium to heal. Technique is basically important. So I'll show you a slightly different technique on the right-hand side, where essentially what you do is, so this is with a different dissector. This is the dissector I use currently now. So once you basically dissect the anterior plane on the surface, what you will do is instead of going inside, instead of coming out through the main incision, once you basically open up the anterior plane, you simply come back to the main incision. So you'll see the dissector basically coming backwards now in a minute. So as it basically comes back towards the main incision, you come back. So don't go out of the incision, and you simply just put into where you basically have opened up that posterior plane. And because the dissector is so thin, it will automatically go into that posterior plane, and you'll basically be able to carry on with the rest of the dissection. So you don't have to even keep on coming out of your main incision. Okay, so suction loss is obviously probably the most feared basically complication, and it can occur at any time, of course, during the procedure. Typically, it occurs during the anterior lamellar cutting, but like you can see on the left-hand side in this patient, it's occurring during the posterior lamellar cutting. And your outcomes and management are going to be dependent on where it basically occurs. If it occurs early, it's often because the patient's a bit nervous. If it occurs later, often you can see this fluid coming into the edge of the suction cone over here. Patient basically moved, and you can see that's why it basically got suction loss. Okay, you can see this is during the posterior ablation. If it occurs late during the posterior ablation, so it's near the visual axis, I'll show you basically how you manage this case. This is one of the first papers that were published on the management of suction losses back in 2014. Some of the things in this paper you can't do now because they basically don't allow you to do on the laser. But back in 2013, we were allowed to do it because there weren't any guidelines, which I'll show you on the next slide. So our incidence in our first 340 cases was only about 3.2%, so not so bad. Most of the time, you can see where they occur during the creation of the lenticle. They were occurring on the anterior surface of the lenticle, not on the basically on the posterior surface. The interesting thing is that in most of the cases, you can actually just reapply the laser and get on with the treatment during the same setting. Okay, so at 82% of the cases, we can basically reablate. If it occurs during the posterior cut, I would actually convert to basically either doing surface ablation or basically doing LASIK. I wouldn't carry on creating a basically lenticle. But if you look at the visual acuity outcomes, they're pretty good. They will be just as good as if the patient hadn't had any suction loss at all. And the visual acuity outcomes at 3 months and the safety index is also basically pretty good. Now there's a protocol for basically management, and it really depends on where the suction occurs. If it occurs early during the posterior lenticle cut, you can restart and reprogram the laser and fire it again. But if it occurs beyond 10%, so it's coming close to the visual axis, I wouldn't advise that you basically do a lenticle extraction procedure. I would switch to doing basically LASIK or basically surface ablation. If it's basically occurring later on during the treatment, during the lenticle side cut or the anterior cut, you can simply re-dock and then basically do the cutting. And generally what I will do is I'll increase the size of the anterior cap. This allows you to get slightly better centration when you re-docking the laser. Because remember now, the patient may not be able to see because of the cavitation bubble because the posterior side of the lenticle has already been cut. Okay. So what about enhancement? Well, one of the advantages of SMILE, as I showed you from our RCT, is that it's actually quite stable, even up to about 12 months. And recently, there's a paper showing that even up to 10 years data, SMILE has basically been shown to be quite stable. So out of our first 500 cases, we had an enhancement of 2.7%, which is pretty good. 14 cases required enhancement, 11 from primary undercorrection, and 3 basically from overcorrection. But interesting, there were no cases of frank regression. And using multivariate analysis, you can see the risk factors for enhancement were basically older age, higher spherical equivalence, high degrees of myopia, and high degrees of astigmatism as well. What are the options for basically enhancement? These are basically your options. Most of my patients prefer to do a surface ablation treatment. You must remember that you must use mitomycin C for the same amount of time that you use typically for your virgin cases when you're doing surface ablation, but you must use that even if you're doing a -1 diopter treatment. Most of our enhancement procedures have been less than basically -1 diopter treatment, but you must use mitomycin C for the surface. You can convert that pocket into a circle, okay, or it is possible to do a thin flap LASIK on top as well, but most of our patients prefer surface ablation. So lenticle extraction, of course, is here to stay, I think. I mean, it's been evolved over the last 10 years, and now we have many other machines that can basically do this procedure. You can see the Schwind over here. The Alcon have a UV system that can do lenticle extraction. And of course, the Zima femtosecond laser can also basically do lenticle extraction. This is a comparison of the 3 lasers that are currently in clinical trials. So this is the Schwind on the left-hand side. Their lenticle extraction procedure is called SmartSight. The Visumax in the middle, which is called SMILE, and the Zima, basically, which is called Clear on this side as well. And these are some of the specification differences between the different machines themselves. The key differences are that the Zima works in very, very low nanojoule energies, much lower than the Visumax and the Atos. And of course, it's the same machine that you do your cataract surgery on. The other differences are the Zima is a flat applanator while the other 2 are basically curved. And the key thing about the Atos and the Zima is that it allows you to do the centration once you do the docking. While with the VisuMax, like I showed you in the videos, these have to basically done basically by the surgeon. And there are about 150 cases done with the Atos and about 130, 140 cases done basically with the Zima. This is just some of the programming screens. I won't spend too much time on this because I think Denisse is going to talk about this in a little bit more detail with respect to optical zone choosing and basically, and your depth of cutting. It's very easy to basically program your parameters. It's very similar. You have a choice of doing 2 cuts or 1 cut. I prefer to basically use 1 cut, but if you're starting off, it allows you to get into the right dissection plane. If you do anterior side, it will go into above. Posterior side will go underneath the lenticle. So it makes it easier to understand your different respective lenticle planes when you're doing your dissection. This is one of the key advantages with basically the laser itself, is that after you've done the docking over here, so the suction is basically on, you'll see the programming of the laser, so it picks up the pupil. You can then basically move the lenticle itself or the lenticle creation, and this can control for your cyclotorsion effect, and also you can move it into the corneal vertex as and when you basically want to basically position this. And that's exactly what we've done basically over here, and then this is basically doing a 2-incision side cut. This is one of the key advantages I find basically with this laser system. This is a patient that I did in India where I basically used a prototype of the laser. Like I said, I prefer to use 1 incision on the side. So typically they didn't allow me to use, they changed the incision. So this is just a 3mm incision on the side of the lenticle that was basically created over here. The video is a bit of poor quality because they took it off the feed of the surgeon's facility that I was basically using. But the dissection is pretty smooth. The technique is exactly the same as I basically used for the VisuMax. In fact, it's exactly the same dissector on the surface as well. Okay, so just basically clearing the surface, dissecting the lenticle. It's very smooth. I'd say definitely as smooth as what I basically see with the VisuMax basically dissection. Okay, and again, the anterior surface, and then again, basically doing the posterior surface of the lenticle. And this is basically then removed with a pair of forceps, the same way as you basically do for standard SMILE procedure as well. Okay, so you simply just put it out through the incision. Okay, so these are some of the outcomes from the first cases I did. So this is the first 6 cases that I did. Now they have basically 3 months. I don't have 6-month data because they were basically not through the COVID, but at 1 month, they're basically 100% were basically 20/25 or better. Bearing in mind, this is no astigmatic treatment. This is only basically spherical treatment. So I wasn't able to create the astigmatism. And at 3 months, these are now basically nearly all 20/20 visual acuity, which is pretty good. And the predictability was outstanding. R² constant over here with 0.997, which is quite amazing for a refractive procedure. This is the first cases that I did with this laser. So in summary, the first generation SMILE has been shown to be equivalent to LASIK with respect to safety, efficacy, predictability, but you do need to optimize your nomogram, and you do need to understand how to do centration if you're using the VisuMax laser. SMILE is shown to show less denervation, and you get faster tear film and nerve recovery. SMILE is best for patients who could have had laser, so they have normal topography, but especially in moderate to high degrees myopia, anyone doing sports or risk of basically flap-related complications in certain basic occupations, and of course, people who have risk of getting prolonged dry eye. I don't do SMILE for patients who are very nervous, because with the VisuMax, you do need to have that cooperation, or if they have thin or abnormal corneas, you can still get ectasia with SMILE, albeit rarely, but you can get risk, of course, if you do these forms through keratoconic corneas that has been reported in the literature. And of course, I have a long chat with people who basically want to have monovision. One area of research which has developed over the years has been lenticle reimplantation. So you're taking your lenticles that you've created, and these are basically being used for tectonic, therapeutic, and basically refractive purposes. And there's a company now in Singapore that stores the lenticles for our patients. It's called OptiQ. This is a box that we put the lenticles in after patients have undergone surgery. So thank you very much for your attention.
It was a really great presentation. Really, we cover everything, and we will have some questions at the end. So we will now switch to Dr. Pinkus, which is going to present a case of clear.
Okay, so, I will share my screen.
And for everybody who has questions, please just put them in the chat, and we will ask Dr. Mehta at the end of the presentation.
Okay, well, hello everybody. It is a pleasure to be in this webinar with Professor Mehta and all of our guests. I will present a clinical case of our initial experience at Codet with clear. So this is our financial disclosure. Dr. Chayad and I are clinical investigators for Codet and Zimmer for this protocol. And let's start with the case. This is a 38-year-old male. He is an administrative assistant and he wanted to have refractive surgery. His uncorrected visual acuity was counting fingers in both eyes with a visual capacity of 20/20 in both eyes. His manifest refraction was minus 575 sphere, minus 0.5 cylinder at 22 degrees in his right eye, and minus 550 sphere, minus 0.50 cylinder at 20 degrees in his left eye. A slit lamp examination and fundus examination were normal in both eyes. Here we have the shame fluke tomography with normal maps and a good pachymetry of the right eye. Also, we did a biomechanical tomographic assessment with the Corbis, also with normal values, as well as in his left eye. And this is the Corbis. So we decided to do clear surgery, which clear stands for corneal lenticle extraction for advanced refractive correction in his right eye, and we did femto LASIK in his left eye. So now I'm gonna show you the surgery of this patient of his right eye. So we start with centration marks. Then we did, in this case, we did a one-step docking, but you can also do a two-step docking. Here we can see the screen at the C8, and we're applying the vacuum. And we can position the lenticle and rotating after doing the docking. Now we see it's gonna show the intraoperative OCT, which that has this femto. Here we can see the OCT. We can see the depth of the cap. And now we're starting with the initial dissection of the first incision. In this case, we did two incisions, one anterior, which is this one right here. We are doing the initial dissection, then the posterior dissection of the posterior incision. And then we're going to start doing the whole dissection of the anterior plane first. It's very important that you dissect 360 and go further away than the border of the lenticle so you don't have any adhesions and you can remove the lenticle easily. Now we're doing the posterior plane dissection. And as you will see here, I left a little adhesion next to the posterior incision. Now I'm trying to remove the lenticle, but I couldn't. So I just get in again and remove that adhesion, and then I could finally remove the lenticle. And as we can see here, it is complete. And the procedure went well. After that, we do a gently massage. We didn't irrigate into the pocket, just did a gently massage. All right, so this is on postoperative day 1. Uncorrected visual acuity was 20/25. The eye had conjunctival hyperemia, as you can see in this picture, and patient referred for embodied sensation in both eyes, but especially in his right eye, which was the clear surgery. In the second picture, we can see the interface with a little of dotted haze. Then we see the anterior incision in this picture, and here we can see the posterior incision. On postoperative week 1, uncorrected visual acuity was 20/20. The patient presented mild foreign body sensation in his right eye. And in the picture, we can see less haziness as in the interface, so it's getting better. And here we have an OCT where we can see an hyperreflective line, which corresponds to the cap thickness, which is right here. And we can see that it's uniform and it's smooth. On postoperative month 1, uncorrected visual acuity was 20/20. Patient was asymptomatic in both eyes, and we can see now a clear cornea. This is the anterior incision. This is the we can see there's no more haziness, like dotted haziness. And at postoperative month 3, uncorrected visual acuity was 20/15 in both eyes, with a clear cornea and no symptoms referred by the patient. Here we show the anterior incision, and here the posterior incision, and the central cornea looks pretty transparent. Here we can see the OPD of his right eye, where we can see a good centration of the treatment and a spherical aberration similar to the left eye. That is, this is the one of the left eye with the femto-LASIK treatment. And so this was the video for this patient, but I want to show you another case. Here I show you a video of a different patient. Here we can see how things improve after doing a couple of cases. And you can notice an easier dissection in the anterior incision and also in the posterior incision, as well as with the anterior and posterior plane and the lenticle. I dissected very easily, 360 degrees. So that made removing the lenticle more easily with no effort, as you can see here. So it was a successful case also. So there's prior experience with this femto LDB C8 by Professor Izquierdo and also Professor Mehta, as you heard in his talk. Actually, Professor Izquierdo is publishing his experience in Peru at JCRS, and here is the reference if you want to later take a look to it. And we have some comments on our clear experience at Codet. So patient symptoms were similar in both eyes. We did see faster visual recovery in the femto-LASIK eye, but at 3 months, the visual outcomes were the same, with 20/15 of visual acuity, uncorrected visual acuity. And we have seen good results in eyes with myopia and low astigmatism so far. About the Zimmer's femto LDB C8, we like that this femto has a lot of versatility, as we can use it with cataract surgery, LASIK, and now with clear. The tucking is easy. You can do it in 2 steps, as we do it with our LASIK cases, or in 1 step, as you saw in the first video. And once the tucking is made, we can make adjustment, moving the lenticle or rotating it. So that's an advantage that you can do with other lasers. It also does an intraoperative OCT, and it offers to do 2 incisions, one for the anterior plane and one for the posterior plane. And this can facilitate getting into the right plane, especially for novice surgeons. But you can always choose to do just 1 incision if you want to, if you have previous experience with Visumax Smile. You can do just 1 incision and do it as always. And finally, dissection of the incisions and the lenticle was easily done by corneal surgeons, in this case, Dr. Chayed and I. And so we think it's a good procedure, and we like that more platforms are doing this technique. Thank you very much.
Thank you, Denisse. Very good presentation. So we have a few questions for Professor Mehta. Jod, if you can.
Yeah.
So the first question is coming, I think, from one of your previous fellows, now a professor as well, Dr. Mohammed Karim. He has a very good question, same question I actually was going to ask you, which is, he says, Dear Professor Jod, can you share with us how do you choose between SMILE and LASIK for your refractive surgery patients?
So I think that the key advantages of SMILE, I mean, are that, of course, is the stability at moderate and high degrees of myopia. There's no flap, so people who are doing contacts, when we see them at the pre-op assessment, you know, I ask them about their hobbies, what's their occupation, what kind of sports and things that they're interested in doing and things. And if they're doing anything that's contact, then of course I think that having a SMILE procedure is superior than having LASIK done. moderate, higher degrees of myopia, anyone basically above 5 and above, I think SMILE is first choice basically because of the fact that it's not the fact, like I tell the patients, it's not the fact that we can't get you 20/20 with LASIK. Of course I can, but it's the stability in the long term that I think is superior in SMILE, and that's down to the energy of the femtosecond laser versus an excimer laser. Any of patients, contact lens wearers who are not wearing contact lenses because they've had to stop because of dry eyes or dry eye problems, SMILE is by far the better procedure to do than LASIK. My sister-in-law has SLK. She's a -8 myope. And I would never have done LASIK on it in a million years because her surface is too unstable. Once I got it stabilized on cyclosporine, she had SMILE done. I did SMILE basically for both her eyes. So any of those people, I would choose to do SMILE over LASIK. When I would reverse it, on the lower degrees of myopia, we do have a slight difference in pricing. SMILE is slightly more expensive at our place. For the lower degrees of myopia, I leave it a little bit more open. If people are not doing contact sports, they have -2, 3 myopia and stuff, I tell them that, it's up to you. The results are going to basically be the same. I don't think there's basically a huge significant advantage of SMILE over LASIK in that advantage, unless you're going to have these additional, things like, you do contact sports, you're worried about basically the flat moving. So that's how I basically distinguish that at lower degrees. But otherwise, I do a lot more SMILE than I do LASIK generally.
Right. So let me ask you, Jod. In Singapore and in your area, what percentage of the population that comes asking for refractive surgery will be like in the ideal range for SMILE? Let's say from -4 to -8.
Yeah. So you see the mean myopia here, 85% of the population are myopic here. So the mean myopia here is -6. When I was in the UK, it was -3.
Right.
So you see, I mean, routinely, I will see people coming who are basically 5 and above all the time. And now, I mean, sometimes people who are above 10 or who are 12 sphere, I will still do SMILE on them, but I do a kind of like a custom or custom procedure where I will do a large correction with lenticular extraction, and then I will then do a surface treatment for them basically afterwards. So I will adjust, I will do it as a 2-step procedure. So that's why I end up doing a more SMILE than doing LASIK, because LASIK is just unstable when you're looking at those levels. Even with the modern day excimer lasers, it's just not stable in the long term. Right. So that's why I prefer to do that.
How about from those cases, what's the percentage of patients presenting, let's say, with more than 2 diopters of astigmatism? Is the population more like spherical, more than?
Most of the astigmatism is less than 1.5. I mean, I did a case this morning which had 2 diopters with -8, -2, but most of them have probably about 1.5. When you start getting 2, 3 diopters still, the numbers start reducing down to 2.5. Right. The numbers start basically dropping down.
So that's probably why maybe in your area, in China, Asia, it's becoming much more popular, probably because of exactly the population-based refractive errors. Like, for example, here in Mexico, we have a lot of mixed astigmatism.
Yeah.
And we have probably lower amounts of myopia. So yeah, it depends in different parts of the world. But
I mean, I think that the thing that appeals to me generally is the tear film, the ocular surface is really outstanding, I think, with SMILE. So anyone, a lot of people, if they stop wearing contact lenses, they tell you, obviously they're thinking about having refractive surgery, but if they're stopping because they're getting symptoms of dry eye, if you confocal them beforehand or you look at on nerves, those people are really good candidates for SMILE over LASIK. I can hardly remember people that I've seen who get keratoneuralgia with SMILE, but of course with LASIK, it's well documented. It's well documented. I don't think there's been any report in the literature. I mean, considering there've been 3 million SMILE procedures of any SMILE patient getting keratoneuralgia, and that's got to do with the nerve regeneration.
There's one question, for example, what will be let's say, the most superficial plane that you will go with SMILE? What's your actual typical plane? Like 130 microns is where you?
Yeah, so 130 is the typical. I mean, I still try to maintain an RSB of at least about 280. the reason why I prefer one incision, I can tell you over two, is that basically, as you know, that study from John Marshall looking at biomechanical weakness basically showed your biomechanical weakness comes from that vertical incision. And that's why I use that thin dissector, because I think that it's important to do once you understand that you can do the surgery, is to do it through the smallest vertical incision you really can do. So 2 millimeter incision that I rotate. I'm right-handed, so I rotate it slightly to the right side for me to get access. And 130 is the standard that I will basically do. And then I will adjust the parameters. So if I'm doing a high treatment power and I want to basically drop the optical zone, like I basically showed you, I'm much more comfortable doing that. Say I'm basically -8, -9 diopter, you're much safer doing that with SMILE than you are doing it with LASIK, and mainly because your functional zone is going to basically be bigger. So you can quite comfortably drop your optical zone down 6.2, 6.1, and your effective zone that you will get will basically be about 6.3. But if I did a 6.2 zone with LASIK, I guarantee you're probably going to be around about 6, and your issues with glare and around that zone are going to basically be much higher. So then I start adjusting the parameters dependingly on those outcomes. But the deeper you go for the lower degree, the less issues you're going to have with dry eyes as well. So that's another advantage of basically doing that.
Perfect. Okay, I don't know if anybody has any other questions. I mean, it's already too late for you, Jod. Thank you.
Okay, don't worry. That's okay.
Thank you so much for this. It was a really, we're getting very good comments from everybody. Let's see here. Oh yes, this is a good question from Dr. Almahan. What do you think about, he says, planar or flat versus curved?
Yeah, interface. Yeah, that's a good question. I mean, I think that I have to say, I did a couple of cases when I was in India with slightly higher K readings. And I don't know if you've seen this with the flat appanator. And I could have sworn that I thought I do a two-step docking as opposed to one step with the Z8 when I do the SMILE procedures. And I thought it was decentered, I have to say. And when I centered it on the screen, and the cornea was already marked, so I centered it, I changed it on the positioning on the screen. I mean, there are a couple of things I have to say that about the Z8 that I think that could be made better. And one of them, I think the suction is too high. The second thing is, I don't know what energy you use, but when I was doing it, I got them to drop the energy down massively because I kept on telling them it was too high, because I said, look, I can tell you it's too high because I can see the water coming out of the cornea. So I'm telling you, you could get away with a lot lower energy. So these things need to be adjusted a little bit, I think, which will require a little bit more optimization. I think generally speaking, the more anterior you are, it doesn't make a huge difference between flat and curved, okay? The difference is the pressure, okay? And even if you see on the Visumax, when we dock, we do a very soft dock, okay? The downside of Visumax is if somebody's a bit uncooperative, the pressure is so low, you're gonna get increased risk of suction loss, which will probably never happen with the Z8 because the pressure is so much higher. Ideally, if you don't want to induce any wrinkles on the cornea, the best thing to do would be to use the liquid interface. That would be the most ideal way of doing this procedure, okay? Then you'll get a really perfect lenticle basically being created. I think that I know that with the flat appanator, I think it's going to have some limitations probably on how high you can go. So I'm not sure really if you're going to start doing -10 diopter lenticles, how accurate and what's the quality of the lenticle going to be looking like, because you're really going to be going down a lot deeper into the cornea. For anterior cuts, I don't think it makes a huge difference, but I do think for posterior cuts, it may make a difference in the lenticle quality.
Excellent. No, that's very interesting. And let's see if we have. There's so many other questions, Jod, but I don't want to. I think it's we're already past the hour, so I really want to thank you,
thank you
very much for this really the best presentation I've ever heard on SMILE. It's very revealing. It will help us also a lot in our thinking. So thank you so much for making it for us, and congratulations. Thank you, Dr. Pinkus. If Dr. Pinkus, you want to make any comments?
Just to thank Professor Mehta for giving our this really complete talk, and that's a good thing about having just one theme in one webinar. So we think we get most out of it. So thank you very much, and thank you for all of our guests. That's us. And I want just to comment that this will be this is being recorded, and then it will be available for you to see in our, I think, in our YouTube channel. That's it. Thank you very much.
Thank you very much, Jod, and good night, and
thank you.
Good rest of the day for the rest of the world.
Yeah, thank you. Thanks, Arturo. Good night, guys. Thank you very much. Thank you.